more than 15 times on the COVID-19 pandemic and continues to rally the whole of government to remain alert and vigilant. I wish to appreciate and acknowledge the efforts of all the stakeholders in this response: the health workers, the law enforcement officers, the police, Uganda People's Defense Forces, and the security agencies, and the entire population of Uganda. I thank you all for rising up as one to ensure we all keep alive during this very difficult time. In a special way, I would like to appreciate all the frontline health workers in Uganda. You are the true heroes of this war we are all fighting. Your tireless efforts, sacrifice, commitment, resilience, and hard work are not in vain. This pandemic is evolving every day, but you continue to be strong and committed. We thank you from the bottom of our hearts. Now, as the President usually asks, since all of us are putting on masks, I will now request that I remove mine so that I am heard clearly, if that is acceptable. And please make sure that the rest of us have masks on. The COVID-19 pandemic in Uganda. The World Health Organization categorized the progression of the COVID-19 pandemic in a country or territory into 4 phases. Phase 1 is the phase when there are no cases. In this phase, countries aim to prevent importation by putting in place port of entry controls and restricting travels from high-risk areas. Uganda passed through this phase in February and March 2020. On the 21st March 2020, we registered our first case. Several control measures were instituted, including a lockdown, to suppress transmission and provide opportunity for the country to prepare in the event that the pandemic grows to overwhelming phases. Phase 2 is a phase when a country or a territory has sporadic cases. In this phase, transmission is seen in immediate contacts to confirmed cases, and therefore response measures are focused on containment strategies such as identification and quarantine of suspects or cases. Phase 3 is the phase of clusters of community spread. In this phase, we begin to see cases in clusters in communities, and there is need for extensive containment measures to be put in place. Phase 4 is the phase of widespread community spread. In this phase, there are multiple unconnected clusters of disease and indirect local contacts infected. The response in this phase is mitigation. Uganda is now in phase 3, and I will explain why. We are now experiencing a steady rise in the number of locally transmitted cases in now 33 districts, with a total number of 243 cases. Amuru and Chotera districts are reporting the highest and most sustained transmission in comparison to the other districts. Amuru so far has reported 52 cases and Chotera 46 cases. This is accompanied with emergence of cases among refugees, 51, frontline responders, these are the health workers, 27, UPDF, 8, Uganda Police Force, 2, and immigration officers, 2. The overview of the outbreak is as follows. The total confirmed cases of COVID-19 in Uganda is 685. And many of you will notice that there is a reduction from what was earlier on reported during the day, and I'll be explaining why. The breakdown is as follows. Returnees from abroad, 47. Contacts and alerts, 234. Truck drivers, 337. History of travel to East African countries, 67. Currently, 33 districts in Uganda have confirmed cases of COVID-19, and the districts are as follows. Amuru, Adjumani, Buikwe, Yumbe, Arua, Koboko, Moyo, Gulu, Kitgum, Lira, Soroti, Kumi, Tororo, Busia, Mayuge, Buvuma, Kayunga, Mukono, Kampala, Jinja, Nakaseke, Masindi, Bulisa, Kiriandongo, Chankwanzi, Gomba, Masaka, Rakai, Mbarara, Isingiro, Ntungamo, Chotera, and Wakiso. So far, a total of 1,197 truck drivers have tested positive for COVID-19. Of these, 337 are Ugandans, while 780 are foreign truck drivers. Of the foreign truck drivers, 444 are Kenyans, 222 are Tanzanians, 9 are South Sudanese, 18 are Congolese, 2 are Ethiopians, 12 are Rwandese, 23 are Burundians, 44 are Eritreans, and 6 are Somalis. And as many of you are aware, when foreign truck drivers test positive, they are not allowed into the country. A total of 699 foreign truck drivers have been handed back to their respective countries for appropriate care and management. Currently, there are 560 active cases on admission in 14 health facilities. 496 are nationals and 64 are foreigners. And I will explain why. Because at the time of change of policy, we already had foreign truck drivers in our facilities. And so we cannot discharge them until they have improved and are ready for discharge. I'll now give you a list of health facilities and the number of cases that they are treating. Lira Regional Referral Hospital, 20. Mulago National Referral Hospital, 249. Entebbe Regional Referral Hospital, 111. Hoima Regional Referral, 13. Masaka, 23. Arua, 24. Jinja, 18. Gulu, 37. Mbale, 15. Mubende, 21. Kabale, 2. Mbarara, 11. Naguru, 1. Soroti, 13. And Moroto, 2. Giving us a total of 560. In the same vein, a total of 199 recoveries have been recorded, and Uganda has registered no COVID-19 deaths. Please take note that foreigners are no longer captured in our daily statistics. So you may be seeing a discrepancy between numbers on admission and our total confirmed because of the foreigners that are still in the facilities. I will now move to the issue of discrepancies in results between the government of Uganda and the World Health Organization. On the 20th May 2020, His Excellency the President of Uganda issued a directive that truck drivers who test positive must not be allowed into the country, and their numbers should not be captured as part of the country's statistics, since they are just transiting through the country. He also directed that Uganda's statistics be revised to discount all foreign truck drivers from her case count. At the time, the confirmed COVID-19 cases in the country were 264. And upon deducting all the foreign truck drivers, the case count dropped to 145. Since then, the Ministry of Health issues results without capturing foreign truck drivers. However, we must take note that there were foreigners admitted in our isolation facilities that continue to distort our figures as well. We have noted, however, that the World Health Organization continues to report statistics different from the government of Uganda's position. The Ministry of Health has formally communicated to the World Health Organization to rectify this error, and this will be reflected in their reports as soon as it is worked on. And we have received confirmation that this is being corrected accordingly. We'll now move to the issue of laboratory testing and turnaround of results. Uganda has been strengthening her laboratory system over the last decade to be able to respond to and provide adequate care for routine health services and public health emergencies, such as outbreaks, in a timely manner. This involved establishing of a laboratory network linked to a series of district-level laboratories that we call the hub system. There was substantial infrastructure investment initially for viral hemorrhagic fevers like Ebola and for influenza surveillance. As such, the National Influenza Center was established in 2007 at the Uganda Virus Research Institute to conduct surveillance for influenza and influenza-like illnesses such as the coronaviruses. The National Influenza Center functions as a center of excellence and referral for testing samples in the East African region. Uganda Virus Research Institute is at the center of quality assurance for our COVID-19 testing. To date, Uganda has tested 148,960 samples of the COVID-19, an average of 1,241 samples per day, the highest number being 3,758 samples that were tested on the 7th of June 2020. The country continues to scale up COVID-19 testing capacity to 10,000 PCR tests per day in the event that the need arises. Initially, COVID-19 testing was carried out exclusively at the Uganda Virus Research Institute through the National Influenza Center. From the start of the pandemic, we plan to expand the number of laboratories testing for COVID-19 in view of the projections as guided by the scientists. With growing need for testing as the pandemic has evolved in Uganda, a strategy to decentralize testing and quickly ramp up available testing facilities was developed. A team of laboratory experts from Uganda and our health development partners, including the World Health Organization and the U.S. Centers for Disease Control, conducted extensive assessment of potential laboratories that could support this exercise. Several labs were assessed against a stringent international checklist for safety, testing capacity, and technical competence to test, and out of these, 9 laboratories met the required standards. And these include Makerere University Department of Microbiology and Immunology, which is already activated to test the samples. The Central Public Health Laboratory dedicated a capacity of 2,000 tests per day to COVID-19 testing, and will continue to provide HIV viral load and EID services effectively. The third is the Infectious Disease Research Collaboration Laboratory in Tororo District. We have the Joint Clinical Research Center Laboratory, the UVRI Plague Laboratory in Arua, Muni University Laboratory in Arua, Gulu University Laboratory, Rakai Health Sciences in Rakai, and the JMedic Fort Portal Regional Referral Hospital Laboratory. Following this, we expanded testing to the Central Public Health Laboratory in Butabika on the 18th of May 2020. This laboratory carries out at least 2,500 tests per day. Makerere University College of Health Sciences Laboratory was among the laboratories that was deemed ready and activated to complement the Uganda Virus Research Institute testing. This laboratory started carrying out COVID-19 testing on the 30th of April during the rapid assessment survey and undertook 24,285 tests. The laboratory continues to test COVID-19 samples across the country. Subsequently, COVID-19 testing has been decentralized to the following general and regional referral hospital laboratories. We have Adjumani General Hospital that has PCR testing machines to support a legal point of entry in Amuru. We have Tororo General Hospital to support Malaba and Busia points of entry, and Mutukula at Mutukula point of entry. I'll now move to the issue of concerns about discrepancies in laboratory results. Errors in handling test samples is not uncommon in laboratory management. That is why multiple tests are done, and there is a provision for a second and third parties to do confirmatory tests on the same samples if need arises. Some of the factors that can cause errors in test results include limitation of the test itself, and others are due to processing errors or errors leading to false results. And this can be classified into the following. We have errors before analysis or pre-analytic errors, which may arise during sample collection, packaging, shipping, or opening. Two are errors that may occur during the sample analysis, and we refer to them as analytic errors, during the sample processing or conducting the test itself. The third may be errors that occur after analysis, and these are the post-analytic, which may occur during reading results, analyzing results, interpretation, decoding, or making the right inferences or conclusions of the results. Between the 3rd and 4th of June 2020, a batch of 50 samples from within Kampala area was analyzed in Makerere University Laboratory and yielded results that were detected as positive. The results were communicated to the respective individuals as part of infection prevention and control, and the necessary measures were undertaken. However, as part of routine quality assurance procedures, some samples from this batch were sent to the Uganda Virus Research Institute for retesting. There was discordance in some of the samples in this batch. This then required the entire batch to be retested. When the batch was retested, some of the previously confirmed positive cases, there were 9 in number, were found to be negative, and the individuals were informed accordingly. This discrepancy was also brought to the attention of His Excellency the President. Moving forward, the following will be intensified: frequent quality control procedures, increase the number of personnel in the laboratory to match the workload, continuous training of laboratory staff, regular calibration and maintenance of equipment, frequent validation of reagents on the different machines. We would like to reassure the public that this was an isolated error and does not affect all other tests that have been conducted, since quality assurance is an integral part of laboratory testing. The 9 cases have now been discounted from our statistics to give a total confirmed number of 685. We appeal to the population to disregard the false stories circulating in both print and social media. The Ministry of Health recognizes the invaluable role played by Makerere University and the professionalism by which they handle their duties. And this is exhibited by the fact that the error was quickly detected. As you may all be aware, the Ministry of Health changed the results reporting time to 11 a.m. daily. This is because, with the increasing number of samples being collected and tested daily from multiple testing facilities, it is important to ensure quality process controls are in place, an adequate time to do this, so that the results are accurately communicated. I'll now move to the issue of COVID-19 infections among health care workers. It is well documented that the pandemic has disproportionately affected healthcare workers. It is estimated that infected healthcare workers currently contribute about 7% of all the global COVID-19 infections. In total, 450,000 healthcare workers have been infected worldwide. In Uganda, to date, a total of 27 frontline health workers have tested positive for COVID-19. Countries where the burden of disease is highest have registered many healthcare worker deaths. By the beginning of June, the United States is estimated to have lost 600 healthcare workers, and the United Kingdom nearly 200. Back home, God has been merciful to us. We have not registered any healthcare worker-related deaths. It is therefore imperative that we continue to protect frontline health workers adequately and offer them optimal care if infected, with respect and dignity. Similarly, the Ministry of Health routinely tests all health workers working in isolation facilities and points of entry every after 2 weeks based on the high exposure to COVID-19. Upon confirmation of the first health worker infection in Uganda, in Lira Regional Referral Hospital, a team of experts specialized in infection prevention and control, case management, and psychosocial management were deployed at the various isolation facilities that registered these cases to assess and investigate the possible causes of infection. COVID-19 being a new infection, we take note that there is a learning curve that requires the health workers to acclimatize to new ways of doing things. The following is currently being done to address this. Number 1, continuous training on case management and training of different cohorts to allow for rest and rejuvenation. This means that the case management teams may be 3, 4, or 5 for any isolation facility, so that if one cohort is tired, another cohort is available to take over. Number 2, ensure continuous training in infection prevention and control, especially in the procedures of wearing and removing of their protective wear. We take note that this is a delicate area and that the health workers have to have adequate practice over and over again. Number 3, continuous counseling and mentoring to ensure that they adhere to the standard operating procedures. And these have been pinned on all the walls of the isolation facilities, so that even as they are wearing and removing, they continue to refer to these standard operating procedures. We have also provided guidelines on management of infected health workers with respect and dignity. The health workers, when discharged, will be free to return and continue with their work at the front line as they so wish. I'll now move to the issue of personal protective equipment for health workers. The government of Uganda has to date procured personal protective wear worth over Uganda shillings 20 billion. Government has also engaged local industries to reorient their services to manufacture personal protective equipment. Beginning June 2020, face masks, including KN95, surgical masks, coveralls, face shields, aprons, and gumboots largely started being produced within the country, and the Ministry of Health is procuring them from within the country. Additionally, every 2 weeks, personal protective wear is delivered to the districts and the points of entry to ensure availability for health worker protection. National and regional referral hospitals continue to receive their personal protective wear from the national medical stores, along with other essential medicines. I'll now move to the state of health facilities in the country. The Ministry of Health had estimated and prepared 3,200 isolation beds and 378 intensive care unit beds at the national referral hospitals, regional referral hospitals, general hospitals, and health center FOs. To ensure continuity of care with the regular services without disruption, the ministry has now excluded use of general hospitals and health center FOs for treatment of COVID-19 cases. The Ministry of Health is now in the process of expanding additional bed capacities at the national referral hospitals and regional referral hospitals using mobile hospitals in open spaces next to the hospitals for auxiliary care. In the worst case scenario, more tents can be mobilized and put in more open spaces like the stadiums and church premises to manage mild to moderate cases. The following measures have been undertaken to increase bed capacity. 300 beds have been added to the previous 100 beds in Mulago Hospital, increasing the capacity of Mulago alone to 400 beds, all dedicated for COVID-19 treatment. Once the renovation works of Mulago is completed, the bed capacity will be further expanded to its full capacity that stands at 900 beds. Mulago's intensive care unit is ready with 36 adult and 27 pediatric intensive care unit beds. The evacuation of Women's Hospital has begun to pave way to provide 450 beds with 35 adult and 30 pediatric intensive care unit beds. 14 regional and 2 national referral hospitals each has prepared 30 isolation beds, giving a total of 480 beds. Each of these hospitals is now being equipped with 10 intensive care unit beds, and this, if multiplied by 16, provides a total of 160 intensive care unit beds across the referral hospitals. This will provide a total of 2,118 beds. The Ministry of Health plans to increase the bed capacity of the 13 regional referral hospitals by erecting a 270-bed mobile hospital per regional referral hospital. This will create an additional 3,510 beds across the country. In addition, I earlier communicated our plan to expand intensive care unit capacity in the regional referral hospitals and national referral hospitals. I am glad to report that there are 108 ventilators that have arrived in the country and are currently being installed in various isolation facilities to support the COVID-19 response, should the need arise, and as guided by the specialists. This is in addition to the 75 that we previously had. His Excellency the President has guided us to prepare for the worst-case scenario by ensuring availability of 40,000 beds by setting up mobile hospitals with 300 beds each and training adequate numbers of health workers to man them. Preparations for this process has started. I'll now move to the impact of COVID-19 on continuity of essential health services. Uganda continues to be faced with other disease conditions such as malaria, respiratory diseases, maternal, child, adolescent, and neonatal health conditions, HIV, tuberculosis, and other non-communicable diseases. In order to optimize and sustain uninterrupted essential medical services, the Ministry of Health established coordination structures at national, regional, and district levels. Guidelines were developed and disseminated to guide districts, health facilities, and communities in regard on how to reorganize and maintain essential health service delivery during this period. Following the outbreak of COVID-19, the Ministry of Health has noted the following changes in essential health service utilization and delivery. Number 1, TB, malaria, and HIV/AIDS services seem to be uninterrupted by the lockdown measures. We appreciate all our partners who quickly oriented themselves to handle this and ensured that patients continue to get their drugs uninterrupted. The number of malaria cases diagnosed and treated increased by 56% between January and April 2020. Antenatal care for attendance decreased by 7% between March to April 2020 compared with the same period in 2019. This mostly affected the northern and southwestern regions of the country. Number 4, health facility deliveries have decreased by 10% between March and April 2020 compared to the same period in 2019. Number 5, immunization services also experienced the same pressure across the country, causing a 20% drop in the number of children receiving DPT-3. The following interventions are being undertaken to support the continuity of essential health services. The Ministry of Health has procured 71 ambulances as part of the regional emergency and referral services. These ambulances will soon be received in the country, and the breakdown are as follows. The government of Uganda paid for 38 Type B ambulances, 3 boat Type C ambulances, and 2 Type C negative pressure ambulances. Again, government of Uganda, through a loan from the World Bank, paid for 10 Type B ambulances. With support from Gavi, 10 boat ambulances Type B are also in the pipeline, and the Red Cross 8 Type B ambulances. Additional transport equipment, including vehicles and motorcycles, have been provided to the districts for service delivery and supervision. And these were procured with support of our partners, as well as the donations that have been received over time. We are training 400 critical care nurses currently to plug in the gaps of the missing critical care nurses. And lastly, the ministry has embraced the use of ICT solutions, use of online virtual environment for capacity building like Zoom, and contact tracing supported by digital technology. I'll now go to the issue of distribution of face masks. As directed by His Excellency the President, the Ministry of Health launched the mass distribution of face masks on Wednesday, 10th June 2020. A total of 750,000 masks were delivered and distributed to the 4 districts of Adjumani, Amuru, Chotera, and Rakai. Distribution of face masks, the distribution process of the face masks will cost Uganda shillings 2 billion, beginning from the border districts, followed by districts within the cities, followed by districts with cities and municipalities, then districts along the cargo truck transit routes, and finally other districts will follow. Quantification for distribution of face masks was based on the population projections for 2020 from the Uganda Bureau of Statistics. This data showed that 77% of the total population require face masks. The total population is estimated at 41.5 million people. The target population, excluding children less than 6 years, that require masks is over 32 million people. A buffer of 3% was applied, which brings the total need for masks to 32,979,928 masks. The total costs of the masks, including distribution, is 81.2 billion. Please take note that each mask is 2,400 Uganda shillings. The district health officers, working with the local council 1 and village health teams, carried out a door-to-door registration to take note of the numbers in each household. At the districts, the masks are sorted and allocated per sub-county. The masks will be delivered by pickups to the local council 1s, who will distribute them door-to-door with support from the sub-county chiefs, the GISOs, the parish chiefs, and the health assistants. According to specifications, all these face masks are reusable, washable, comfortable, breathable, one size fits all, anti-droplet, and acceptable. The masks will be 3-layered, with an inner layer of 100% cotton, a middle layer made of chiffon, and an outer layer made of 35% cotton and 65% polyester. The masks are labeled Government of Uganda, not for sale, and made out of plain colors. We encourage those that have received the masks to use them as per the guidelines that have been disseminated by the Ministry of Health. Lastly, on repatriation of Ugandans stranded abroad due to airport and border closure. Following government's decision to allow a total of 2,392 Ugandans who have been stranded abroad to return in a phased and orderly manner, the Ministry of Foreign Affairs has made arrangements and communicated through our missions abroad that the returnees must undergo a mandatory COVID-19 testing prior to their return journey. In order to facilitate the process of return, my ministry has developed an elaborate plan of ensuring that all returnees undergo the necessary COVID-19 preventive measures. The process includes the following. Uganda will receive a group of 300 returnees every 2 weeks. The first group will arrive into the country on the 13th of June 2020. The Ministry of Health has identified and prepared a total of 16 quarantine centers where all the returnees must undergo 14 days of institutional quarantine at their cost. We have also assembled screening and laboratory teams to ensure that all the returnees undergo COVID-19 testing upon arrival, and on the 10th and 14 days of quarantine, respectively. If anyone is found positive in the quarantine site, he or she will be transferred to a designated isolation or treatment center for care. As I conclude, the Ministry of Health would like to appreciate the general population for implementing the measures instituted by His Excellency the President and the standard operating procedures issued by the Ministry of Health in order to prevent the spread of COVID-19 in Uganda. We continue to appeal to the general population to practice COVID-19 preventive measures such as hand washing with soap or use of a hand sanitizer. Maintain a social distance of at least 2 meters and always wear a mask when in public. We take note that there is a lot of complacency among the population and would like to remind all of you that your health and that of your family is your responsibility. I thank you for listening to me.
Dr. Jenutha Cheng, for that very detailed, comprehensive report on COVID, again, to the nation and to the public of Uganda. We thank you so much for that. I will now just request that if you are out there ready with a question, please, I will request that you come on, ask a question, and I'll ask my co-moderator, Dr. Misach Wayengera, who will come and help me in apportioning these questions to the different persons whom he feels suitable to answer them. Dr. Jenutha Cheng, we thank you so much. You talked about the 300 returning every 2 weeks, and we do not know until when this will be, because we know there is a batch that is coming on the 13th. 300 in how many phases, or until when will these continue coming? Is anybody out there with a question before we get to, you talked about, if you meant Emma and you call him Dr. Emma, Emma, you need to study hard to also become a doctor, because I heard the minister said Dr. Emma, but if the minister meant you, then she set the bar high for you there to also study and become like themselves. Is anybody there with a question before we proceed? Scovia, Carlton Scovia, come make a question brief. And today they decide that everyone will ask one question. At least introduce yourself and your media house, because we know of some fraudsters who come here and they purport to be working with certain media houses, which is actually not true. So it's prudent that the world knows where you're coming from and who you are. Welcome.
My question would go to the Minister, Dr. Acheng. Would like to understand if in these investigations into the false positives, you've engaged the national medical stores to ensure that all batches are validated and the they're very correct.
Scovia from BBS said that again. You want to find out from the minister whether the batches are what? Verified?
Whether they've engaged the national medical stores.
Okay.
Yes.
Whether you've engaged the national medical stores, Dr. Cheng, to verify the batches, I think, which you have.
Which batches? Reagents. Yes. Yes. Would like to understand how much Uganda spends on every patient being treated for COVID-19 for the 21 days they spend in the hospitals. Thank you very much.
Thank you, Carlton Scovia. That's a very good question. It's also out there in the public. Scovia has represented so many Ugandans who would love to know how much it actually costs for one to undergo the treatment, because when the president was addressing the nation someday, he said if it's possible, we could even actually ask those very reckless Ugandans to be treated then thereafter, maybe find how to get our monies from them for their carelessness. Walter, do you have a question? Yes, you're welcome. Don't ask so many questions today.
All right, thank you very much. Been limited, but I think there's a feeling out there about the comments from the Honorable Minister, Dr. Cheng, about a suggestion that we may get back into lockdown if we don't observe the guidelines that were given to the public. We would like to understand, are you really considering another lockdown, or, you know, what else are you planning to do? Because the nature of most businesses in Uganda, especially downtown and around town, is that they involve a lot of contact, and there's basically no way you'll tell people not to go to Chikubu unless you keep closed. And the fact is, you can't, you know, lock down a country forever. Thank you.
Thank you so much, Walter Mwesje from NTV. That's a very good question also. We're really trying to do social distancing, but it's practically very hard in some places where some people do work, especially the markets. We've allowed that marketplaces keep open, but social distancing in markets is a dream far away from reality. Welcome, Namuli from NBS TV.
Yes, well, quite hard to answer, but the public would like to know, because some information may have leaked, and we cannot ignore the fact that it could be false information. On the Makere era and where it came out, some people think, could it have been a question of ego and infightings between the several laboratories that have been accredited to carry out the testing? And some information also has it that the various laboratories, including UVRI and CPHL, had run out of reagents, and Makere remained the president in the game. Is this true? And if so, have they finally got these reagents to the Honorable Minister?
Thank you so much, Zahra Namuli from NBS TV. How many questions are those, Dr. Wayenjera? Those are 4 questions. You came to tell me. Is there any other person with a question? Emma, a doctor in the making, do you have some questions from the public? Okay, if you do not have them there, then I think we'll be. Dr. Kalebu, you had a question from me the last time you were here about the antibodies, and because we know that the PCR swab test doesn't give, or it doesn't show information about the person's immunity to infection again. So what are we planning on as a country, or what are we anxiously waiting for the testing of the antibodies of the virus? We need to hear that from you. And maybe from Dr. Jonas here from WHO. You issued 6 guidelines for all countries to lift their lockdowns, what they should actually follow. Is that what we are doing as Uganda, steady and progressively, or we are doing what we think we are doing our own thing? We need to know whether we are actually following those 6, and the report also that comes from WHO that indicates that the numbers on Africa, or the cases in Africa, might actually get to very worrying levels, because it took us 98 days to get 100,000 cases. It took us only 18 days to get another 100 cases. That seems to be a very worrying situation, and what we need to do about that if we don't lock up again. Dr. Wengira, Message, I request that you apportion those questions and we see who tackles which question as we get to wind up.
Thank you, Moderator Ziksoka. Good evening, viewers. I have 6 questions here that I will allocate as follows. Professor Kalebu, kindly come and answer the questions on the lab. If investigations into false positives, whether NMS has been engaged to make sure that the reagents are okay. That was question number 1. The second question is on the cost of testing. Cost of treating, not testing. Okay, great. So that will take it away. There will remain 3 questions. On the issue of Makerere error, could it have been a case of ego? And at the time, other labs had run out of reagents. That you should be able to comment about it. And then the plans for the antibody tests. Those remain 3 questions. You're welcome, Prof.
Thank you very much, Chair, and thank you very much, the moderator. Do you allow me to remove?
I will allow you because you need to be very clear
since all the others.
Yes.
I think these are all very important questions. Batch testing. When we talk about QA, QC, always batch testing is important. All of us who procure reagents and who do lab tests, we include this in our quality control, quality assurance measures, in that we've validated the batches. But even before you do that, one step we do is to ensure that we procure from well-qualified and good manufacturers and suppliers to reduce on variability of your results, because they could vary your results and get discrepant results because you have reagents, different batches. So it's one of those steps that is done in the the quality assurance system to ensure that your batches do not vary. So indeed, yes, this is done, but not by, for this case, for the COVID testing, not necessarily by NMSs, but the labs that are testing, doing the tests. It's done for some of our reagents. So the other one is it ego in the labs in fighting? I don't think so. In fact, the labs are working very, very closely, yeah, because the labs that are working on COVID are not new labs. We have not worked together on COVID alone, yeah. We have been together even in other diseases, HIV and the rest. So we know each other and work very closely together to ensure that we serve the country. Many of us leading these labs are very senior people who have worked to serve the country for many years. I don't think COVID can make us stoop so low to start infighting. There's more to this country than just COVID. So I want to assure the public that this is not infighting. We are trying to do the best. The leaders of these labs are very professional people, well qualified, who have been doing a good job for many, many years. So don't put us so low to that extent. Of course, the way we have worked is that if one lab does not have enough reagents, you can borrow, you can work with others and you get the reagents so that you can work together. And this is what we are doing. Let me assure you, tell you one thing. When COVID testing started, many of our labs used our own contacts, yeah, partners and the rest, including, of course, WHO and others who came in to bring the reagents. We did it in UVRI. Makerere has done it, working with our partners to serve the country, yeah, to serve the country, and that will continue. So I think those who are talking about egos and infighting are putting us a little bit low. We are above that. We are serving the country and want to ensure that we provide the best results. I saw the newspaper news today, and I said, this is hopeless, as I could say. And my colleague, I think, Professor Joloba, will assure you that we are not infighting, but we are providing the best for this country. And when labs, reagents get depleted in one lab, we do share, and we share protocols, and we will continue to serve the country. Finally, on the question of antibodies, you did ask last time. Indeed, antibodies are important, but as you know, antibodies just tell you somebody who was infected before. It doesn't give you the real time of individuals infected as we use the PCR or antigen. But people who have been infected in the past, and they are very good for surveillance, to look for individuals who have been infected in the past. We are evaluating, validating some of these antibody tests. Currently, WHO says don't use them for patient care, but I think as better and better antibody tests come on, they'll be used. And there are different antibodies, IgG, IgM, and we shall also do a study to compare, especially IgM with PCR, whether individuals who still have the PCR positive, antigen positive, do have IgM, so that we can have an algorithm, especially at this era where PCR reagents are expensive and difficult to get. So we are doing this, and we shall be providing results on that. Thank you.
Question about the possibility of another lockdown, and I will request Professor Sengoba to come and respond to this. I think the key thing here to appreciate is that the early lockdown did not abolish the progression of the epidemic in Uganda, and we have a checklist that looks at the capacities that we've developed over time. And if as the cases grow, now that we've eased the lockdown, it is important that we evaluate our capacity for care alongside the cases that are coming through. Professor Sengoba.
Thank you for asking the question. Greetings to all viewers. So, of course, the question was initially targeted to the WR, but I'm happy to say, and I'm sure you can add, that among the guidance that we have used as a country to try and progressively get out of the guideline have been about 6 of them. One is to do with the capacity of the country to be able to have, as we've just been talking about, testing capacity, because testing is very important. And as you have heard from the minister, over
Professor Sengoba,
yes,
this
please.
is about the possibility.
The possibility. Oh, no. I think that one I'll be speculating. But as a scientist, our guidance is that the country has been, I think that's where I was going, that as a country we've prepared for the phase where we are at. And all the last 3 months we've been trying to prepare for the fact that this phase is going to happen and more cases are going to come. And what the minister said in her statement is the various capacities that have been put in place. Competence is that hospitals are doing more care, testing, we are doing more testing, surveillance, we're expanding surveillance. So at this point, unless of course the minister shows alarm, at least we as a team and coming here today, we've not had and don't not yet have that level of alarm that is in the public. Maybe what you want me to say is that so far the situation is manageable and all has been done to manage it. But we do want to appeal to our fellow Ugandans that if we don't follow and comply with many of the measures that have been said, then we can walk ourselves into a more tight situation where this can become inevitable. But this is not yet there, and if we all try to work on those measures, we can still revert to a situation or stage 2 where we have very few cases. So it is within our means, and my message is let's all of us try to do our best. The measures are very simple. We all know them by now. I know in the village side, on the countryside, there's been that feeling that this is a problem of Kampala. But now, from the minister's statement, we've heard that many other regions are beginning to have cases. So it's important that all Ugandans, wherever you are, whenever you're going to the public, put on a mask, try to ensure that you wash your hands, try to clean the surfaces. And I know the market issue has been said, and that's where we are likely to get a lot of challenges downtown and all markets. I think it's also important that as you go in a market, don't crowd around the same place where they are selling stuff. Try to have call it a distance. Wait for the other person to be served so that you can also approach. Otherwise, if you all crowd and that becomes the norm, then we will get a lot of infection. So let's try as much as possible. If you're a manager of a business, help your clients to see that they go away safe. If you are in the marketplace and you're lead of a market, please give guidance, provide the sanitation, and ensure that we help each other. If you are the head of an office, also try to ensure that your employees are following these guidelines. If we all work together, I think this situation is within a manageable range, and that also means that the lockdown can be literally ruled out. Thank you very much.
Dr. Sengoa, just before you maybe go back, do the numbers that we see today still reflect the model that you had ideally? Because I think you had a model of how to manage or suppress or do anything. Do the numbers that we see still communicate the model that you ideally had to manage this?
So absolutely. Of course, when you lock down very early before numbers come, you have an opportunity to delay and what people are calling flattening the curve. And that delay is strategic, is you go and actually prepare, because no country has come out of a lockdown and found that there was no case of COVID at all. Actually, many of the countries that did the right thing and locked early, when they slowly unlock or release the lockdown, there is a number of cases that start to come up, but they find the system that is actually capable to handle. And that's why we said we didn't want to overwhelm the whole system. If we didn't lock down very early, we would have seen the pictures that we saw in Europe, because many of the situation there was people let the infections to become build the momentum that then the hospitals were literally overwhelmed. But we are now in a situation where we are able to titrate the lockdown measure, but also build our capacity. And God has also been on our side. So we haven't yet gone out of the scenario. As you hear now, we are being asked to prepare for the worst. But as scientists, we are still feeling that if we continue to, to appeal to the public, this is a situation we can still revert. And we have already sacrificed a lot during the lockdown. I don't think that what we are being asked to do, wearing a mask as we speak, or trying to delay being served, is too much to do. So if we want all to see the economy working, we also have to sacrifice some bit of delay waiting here and there. And some people fear to speak under a mask. I'm one of those. It's taken me some days to get comfortable to speak under a mask. But these are things that we need to sacrifice if we are to collectively protect ourselves and to see that the normality comes back early. Thank you very much.
Thank you, Dr. Sengoa. Thank you.
The question on the cost for treatment, I'll request either my PS or the DG to come and talk about this.
Dr. Mairasa, welcome. Yes, you're welcome.
Thank you very much, Chair. We have been looking at this. You recall that we take about 16 to 18 days for every case that is admitted. We take 3 tests, the initial test, and then the repeat test, 2 repeat tests. Patients on admission are usually on ascorbic acid and a few on hydroxychloroquine and the comorbidities. The cost may also be affected by staffing and feeding and the PPE. So in general, we have to compete for all those. The test of admission, the 3 tests on day 0, day 14, and day 15. Really, the medicine is not very expensive. It's mainly ascorbic acid. If you have diabetes, they have to treat your diabetes. If you have hypertension, you'll still get the treatment anyway for hypertension. Even if you were not COVID, you'd still require that treatment. the staffing, and the PPE. So we shall compute that, and we shall come back with the actual costs. As of now, we don't have the exact figure, but mainly the cost centers the PPE and the feeding and the staffing. But the treatment is not very costly. It's mainly ascorbic acid.
Okay, thank you, Director General.
We will allow you to come back next time, though not very satisfied today, but that's okay. You've not computed them, so we'll allow you to come back next time and compute. I'm only worried that Zahara is now thinking about PPEs for whoever asked that question. I think Scovia. She's thinking whether PPEs per patient or PPEs can cater for a number of persons there. But you've promised that you will answer that question next time. Thank you.
Okay,
Dr. Waijira.
WR, kindly.
Sorry. Of course, that is only the mild cases, in the case of mild cases. But in the event that we get the severe cases, then we have the oxygen, then we have the ventilators, and the ventilators. And that takes a little longer. Such a patients may go on for about 4 weeks in the hospital. So that makes also the cost a bit higher. But as of now, I cannot give the exact figure, how much we spend on each patient. But as you know, our patients have been mild to moderate, so our costs have still been low.
Thank you, Dr.
Thank you. So I may not give exact figure to Zahara, unfortunately.
Carlton Scovia, that was Scovia's question from BBS, but it's okay. She will get answers next time.
So the last question was about the guidelines issued by WHO, and it's good that the WR is here.
Okay. I'll address both your questions, and I hope it's audible. I don't need to remove my masks. As you know, by today we have about over 7.5 million people infected, and within the last 24 hours, 136,000 people infected. And the world has seen now 422,770 deaths. Of this, Africa accounts to 222,238 infections, 6,017 deaths, which is about 2.4 case fatality rate. But what is worrying is Africa has seen 5,163 health workers, of which 2,084 of them are just in South Africa. So your question, I agree that we have seen acceleration of cases in Africa, and mainly it's driven by a number of countries in West Africa, DRC, and South Africa. So Africa is, as you said, the doubling time of cases is becoming shorter and shorter. So our worry as WHO is Africa might be the next, now the epicenter being in Southern America, Africa could be the next epicenter for COVID. And the case fatality rate is slightly less compared to the global average, but it's not dramatically different. So we get worried here as well. As you rightly said, WHO considers 6 criteria when easing lockdown. And as I said last time, you don't have to have 100% in each of the 6 areas. Any government, any institute, any individual doing that, and the scientists have a detailed checklist, have to see how much of each of these criteria is fulfilled. We would like to have no transmission, but that is impossible. We know that. How much of the risk we take? We see that our health services have to be capable of detecting, containing, treating all cases and contacts. And here we see Uganda has increased its capacity in doing that. So that level of increase will be important when one considers easing or locking down. But also Uganda has taken another aspect of lockdown, which is geographical lockdown. As you have heard, that now the lockdown has not been eased in the border districts where we have a higher cases, while the lockdown is easier in the center of the country. So that is another aspect which Uganda has made some progress. The other things we look into is ensuring certain locations are safe, like schools and workplaces. And you have seen that the Ministry of Works has put a criteria how workplaces should be managed, and I'm sure the Ministry of Education is looking into how to make schools safe. The other thing we consider is making sure safe populations in places, especially where there is vulnerability, which is health facilities and where we take care of vulnerable people like the elderly. And I think all we are trying to do in infection prevention and control is a progress in that aspect. And the very fact that Ugandan health workers are less infected compared to the average, and even to the numbers we see in other African countries, shows that there is a lot of work going on in that. The fifth criteria is stopping importation, and the screening and the border controls are measures which has been strengthened significantly, as you very well know, which is another measure which is in favor of looking into what kind of easiness should be conducted. But the most important of the six, which is not in the hands of the minister or the government, is the community. That is, the government is educating the community, empowering the community. It is now you as an individual and as a community to take care of your health in your hands. Literally, wash hands, keep your distance, use masks, and this disease will not be a major issue. Thank you.
Thank you, WR. Over back to you, moderator.
Maybe just before you go answer my question now, this is from me to you. We also been told that the collection of samples is what causes the discrepancies in the testings, and more so actually giving us false negatives. I feel a false positive is better than a false negative. What needs to be done because we are, or what is the percentage of that? Because the collection of the samples is, I think, what causes the discrepancies. We were told that also happens. Talk to us about that and what percentage that contributes to the outcome of the results.
There is
or that may cause, yes.
The minister clearly listed pre-analytic, analytic, and post-analytic. But I will request Professor Pontiano, because he is the expert, to come and probably talk about that. But the errors could occur pre-analytically, analytically, and post-analytically. Pre-analytically is the process of collection of the samples. Sorted.
Yes. Then it's sorted.
Yes.
Yeah, it's sorted. I serve my professor. Yes. Honorable Minister, just before you come back to finally speak, there is a question here from the public, from Mwananchi, to Mukunde Lawrence. Honorable Minister, we would like to know how much healings will someone in quarantine pay for the 14 days? Because you said when they come back, they shall at their cost. So you need to communicate that for people to prepare for their relatives who are abroad. We just need to know that from you. And maybe, Emma, you have 2 questions, but there is also rumors out there to you, the PS, Dr. Diana Trine, rumors specifically, social media rumors about you. It is circulating everywhere, how you have built houses during this COVID pandemic, and we're seeing so many skyscrapers skyrocketing somewhere in your name, in your stewardship, I think because of the pandemic. And the world there thinks, but the more you keep us inside, the more you're building houses. Please, you'll come and clarify on that, and we know whether you've built any houses because of COVID-19.
Thank you very much, Emmanuel Inebiona. I would like to first begin by where you stopped. There is also a culture that has cropped up where people attribute words which people have not said. There is a WhatsApp, the Facebook message that has been trending of words attributed to the permanent secretary, which she never said. So I also request her to clarify, and also we need the people to act professionally, not to feed words in people's mouth. The question one is coming from Cecilia Okoth, who is a journalist at the New Vision. She's saying, why does World Health Organization continue to register statistics contrary to what Uganda does? She needs an answer.
That in her update, in
okay,
her report.
Cecilia referred to the statement we've just shared. Then there is a question that came from Nicholas Mwanje from Namugongo. What is the plan for monitoring community transmission following the expiry of the rapid community survey findings? There's another question also. Please confirm whether KN95 is designed for hospital use. The same author asked the question. And another question is to do with PPE for continuity of services. Is saying people who are managing drug-resistant TB had their masks depleted, so they need to know whether they are going to be provided with other PPEs. I thank you.
Dr. Diana, just come and use a few minutes to clarify to the public. It would have been a disservice for you to come here, and we'll let you go without telling us the truth about what is happening to you lately before the minister, about your new houses especially, before the minister addresses us.
I'm the tycoon of the town. First of all, thank you so much. As we deal with the COVID-19 pandemic, we need also to get prepared for epidemic of falsehoods. Epidemic of falsehoods, epidemic of distortions, epidemic of malice, epidemic of misinformation and propaganda. That one, I think, is a package. It has come, it's a big package with pandemic, with the negative propaganda and then distortions. So all these things that you are seeing on the social media. Today I was so amazed. And I want to read it because I shared it with my colleagues here. And someone went on a website of, Facebook called Voice of Gomba. And he wrote that Permanent Secretary Dr. Diana Atwin has once again come out to rubbish President Yoweri Kaguta's words. This time she was diluting allegations by the president, who said that some COVID samples at Makerere were confirmed positive. She said that was a wrong move by the president, that this wasn't the fact. So you can imagine, it is a long post.
So where did you say that from?
It is on, by the way, it has been pulled down.
Somebody is purportedly quoting you. Where could you have said that from?
I don't know. Okay. I have not said anything. I have not talked to anyone. Actually, to me, I had it much later. I wasn't, I didn't have all the information. But what I want to say, that part of the battles that we need to face, I think all of us, not just at the ministry, but the scientists, the health workers, the government people who are involved in this COVID. We need to brace ourselves with this kind of attack, that we shall be attacked every day. We shall be maligned. The stories, you saw the floods all of a sudden in 2 months of COVID. I built 3 big apartments. Then all of a sudden, the owners came up and said, "Why are you taking our apartments? These are our apartments." So you have also seen something circulating about my minister here, about cannabis and what. It is an attack, and by the way, it is going to intensify. Some of these people, I have been informed that they attack you, you call them, they think we have a lot of money. They think, that's what I've been told.
Oh, you have it?
By some people here. They told me that if you have money, your target of malice, so that you call people, you give them money so that they keep quiet. For us, we don't have money to give to propagandists.
Yeah, but just
we are given,
by just accepting to give them money is actually a confirmation that you're telling them not to say what
we
you
will
have.
never give any money. You go ahead and blackmail and write all the trash. The truth will come out, because now the owner of the flats have owned them. Now people are quiet. Now this one of the results, the minister has stood here. He has clarified. The experts are here. They have clarified. So now what?
Thank you so much.
Thank you very much.
Thank you so much, Dr. Diana. And unfortunately, when I looked at those flats that you own, I happened to knew one that belonged to somebody else. So I wondered how you had actually. But I'd known that one belongs to somebody. So when they also said it is Dr. Diana's, I possibly thought you didn't just build it, but bought it maybe. But thank you for the clarification. Honorable Minister, we once again welcome you to speak to us finally. Except if Dr. Nelson also has something to say.
Okay,
but
before I conclude, allow me to request Dr. Henry Kajumbula to come and talk about the N95 and the KN95. And the questions were whether KN95 is designed for use in a hospital care setting and for COVID patients, and whether we are not depleting the N95s that are meant for TB patients. Please.
You please take the stand here.
Thank you very much. Good evening, viewers. Yes, I think the background behind this question is there's a batch of KN95 masks that came out, and these were clearly labeled by the manufacturer that not for medical use. Maybe I'll tell you about what these masks are. N95 and KN95 masks are named so because they have the ability to filter out 95% of the smallest particles, okay? 95% of the smallest particles, so they will protect us from infections that are transmitted through the air, airborne, such as tuberculosis. They would even protect us against those that are transmitted by droplets, such as COVID-19. So that is how they are defined. So ideally, they should be able to be used in various settings to protect us against these. However, I think the reason this particular batch was labeled, one of the things is that they should be able to fit, very closely around the nose and the mouth so that there are no leakages on the sides. So if one is made in such a way that it may be able to filter very well, but if it does not fit very well around the sides, then it will not be efficient. It will not carry out its work effectively. One thing I notice about this particular batch is that the loops to the ear are relatively weak, so they could snap after some time. So while it may fit very well and perform its work efficiently, if, say, someone is in an isolation unit where we are exposed to these airborne infections and droplet infections, it might snap during the course of one's work, and then it may not be effective. So the manufacturers, while did not design it specifically for use in that setting. So I don't know if that captures the essence very well.
I think that's okay.
Thank you. And then about depleting masks for TB, there has been what do you call it? Estimation of a quantification of needs. Okay, quantification of needs of the personal protective equipment, that is masks and other things that are needed for the COVID pandemic, and the quantification for routine use, okay, for the other uses. So the procurement actually take into consideration the other uses other than the COVID-19. So that is how it's being done currently at the ministry. So these other needs should be catered for. If at all anything happened, maybe that healthcare facility used some and had not yet used some meant for TB and had not yet got its stock for COVID-19. I don't know, but there is quantification and procurement to cater for all of these needs. Thank you very much.
Thank you so much. Honorable Minister.
Allow me to appreciate the scientists and everyone who has answered questions. There was a question on the cost of quarantine. Allow me to state here that the costs of quarantine vary. We have identified high-end hotels, middle-level hotels, low-cost hotels, and we have also prepared classrooms for those who cannot afford completely. We have made these hotels known and available to the Ugandans abroad to identify where they fit, and they will choose accordingly. For those who cannot afford, we shall keep them in the classrooms that are cheaper and more available to us. Of course, that means that government will have to shoulder the costs of feeding and the costs of security in these hotels. So the costs vary, and I will not point out the costs of the hotels as they will be identified by the people, and the costs will be provided by the different hotel owners. It is not for me to determine what the hotel owners will charge the people in that event. Now, allow me to say two things again. One is on social media posts and diverting attention. We must appreciate that this pandemic is huge, really huge, and it needs minds that are sound, very objective, and working very closely together. So the social media people who are trying to distract us from what we should be doing is really very unfortunate. And want to appeal to all of you to stop giving wrong information to the public. If there is need for clarifying any information, please do consult us. The Permanent Secretary, Dr. Diana, will be coming back next week to give accountability for the funds that we have been choosing. And again, we want to reassure you that there is no way the Permanent Secretary can touch the money for COVID-19 because it is done as a team. And you will be seeing how the country has been making the expenditures. I also want to appeal to those who have other issues to address outside COVID-19. Instead of allocating us businesses and making me a director in an Israel company growing growing marijuana, please take off time and do more useful things. I don't know this company. I've never met the directors. I don't even know which is their farm. But now I am a powerful director taking decisions there. If you are interested in growing marijuana, please be patient and wait for cabinet, government, to take its own decisions, and then you will be formed accordingly, and you will apply according to the decisions of government, or if the government decides otherwise, you will also be informed. I have also noticed social media circulations, and I guess that is why one of the questions came from, that the Health Minister, Jane Ruth Acheng, has suggested that the country needs a fresh lockdown, a fresh total lockdown of at least 3 months following the current rapid spread of the virus in the country. Dr. Cheng adds that a total lockdown can help to analyze how far the virus has spread in the community through increased mandatory testing, so as not to drive the country into a worst-case scenario which may be so hard to handle. And this is next 256 updates. Next, I want to thank you very much for trying to put words in my mouth.
Which you didn't say.
Which I did not say. But I will explain that Uganda has not yet even come out completely out of the lockdown. As the WR explained, the country is beginning to ease the lockdown. But it is true that we are seeing an increasing number of cases, as was expected. However, it is important for people to take responsibility to ensure that they don't get infected. Because as the numbers continue to increase, there will also be health worker fatigue, and eventually we shall start recording deaths. Perhaps Ugandans want to see deaths. But as His Excellency the President explained in his address on Heroes Day, please, let us work hard to ensure that we don't lose any Ugandan to COVID-19. It is preventable, and we can all avoid it by trying as much as possible to follow the prescribed measures of prevention. We take note that there is a lot of complacency, and we have observed this in the taxi parks, in the bus parks, in the markets. But it takes an individual to put on a mask, to wash hands, to keep your distance. You don't need to wait for the Ministry of Health to come and remind you, or for the President to continuously educate you, and you don't adhere to the measures. COVID-19 is still with us. COVID-19 is real, and COVID-19 may kill. The WR has clearly elaborated the statistics, and again he has emphasized the fact that in Africa we are seeing a very quick doubling of cases, which may also happen in Uganda if we don't take serious control of our behaviors and also implement the measures accordingly. Somebody asked about a rapid assessment. Yes, we had a rapid assessment that was very professionally done by the Makerere teams. We have been planning for another rapid assessment, but we have to take note that the rapid assessments themselves require funds and require test kits. We cannot continuously rely on rapid assessments. We have to be responsible citizens first. Currently, we are planning for a rapid assessments in the districts that have reported the highest numbers of cases, and this include Amuru, Adjumani, and Gulu, and down south, Chotera, Rakai, and Isingiro. And then we shall see what will happen as the pandemic evolves and plan accordingly. But again, we should not be relying on the rapid assessments picking out cases. We should be relying on ourselves, ensuring that we don't facilitate the spread of COVID-19 in Uganda. Lastly, I want to appreciate all of you for the enormous support that the Ministry of Health is getting from the entire population of Uganda. Many of you have called us. Many of you have expressed concern about the complacency, and many of you have indeed said we were better off during complete lockdown. But again, we want to remind you that we cannot remain under a lockdown forever. There will be progressive easing of the lockdown, and this will be made more easier if the populations are adhering to the control measures. And indeed, we continue to appeal that please practice the preventive measures. They are cheap and very easy to do. I thank you once again, and God bless you all.
There is one very unique thing that we've not tackled all through, and this comes from a one Haji Rubowa, who says, what about places of worship? Are there plans of reopening them sooner than later? Nobody has talked about places of worship. And maybe on the same issue that you're addressing there, somebody got to you and said the police was arresting people without masks downtown and putting them again in the same place. You also need to, I think, talk to the police. Maybe Lieutenant Colonel Chobe here will help on that. But of course, not coming back to answer it here. And finally, a young somebody here called Dani Kayanja talks about, I beg your pardon, Caesar Bukasa, but I think this will be answered by Dr. Diana when she comes to give accountability, as you said, on the budget that was passed for quarantine and not shifting the burden again to the people. This comes from Caesar Mukasa in Kampala, but I think Dr. Diana will answer that when she comes back to give that accountability report. Places of worship and the police burdening people together.
Well, thank you very much for those questions. As I indicated earlier on, there is a phased lifting of the lockdown. And we want to take note that so far, only 2 steps of the lockdown have been undertaken by His Excellency the President. The first was allowing us to move freely. People are moving freely. And he said, please put on masks so that you move freely. The second was allowing private transport and public transport as long as we have masks. The other steps will be undertaken by His Excellency the President as the pandemic evolves and as we see statistics from the situation. Now, all of us know that churches are part of public gatherings. And churches don't limit people. People gather in large numbers, as large as over 500, 200, 100, large numbers. And you cannot put people to sit 2 meters apart in a church. So such gatherings are very difficult to control. Therefore, it is also grouped in the same category as the schools. Schools also gather a large category of people. We have been trying to address this, work very closely with Ministry of Education to see and find ways of how the finalists can come back and do their exams. So all these are some of the challenges that we are still looking at. And as I indicated earlier, Uganda is now moving to phase 3. Phase 3 means we are beginning to have clusters of community transmission. What if a church is in the area where the clusters of community transmission is happening? What will happen if people gather together? And then how will we follow them up? Because people use public transport to come to church. Others use private transport. How will we know who has gotten into contact with who? It becomes a very big challenge. So I want to request that we still continue to analyze the statistics, observe carefully the evolution of the pandemic before we can start talking about some of those places which gather people in large numbers being reopened. Now, on the issue of masks, there was a directive issued by His Excellency the President on mandatory wearing of masks. And this was to protect us, ourselves, each of us to protect one another. And he did encourage us to get masks and come out into the public so that you can move freely and do your business. But he also committed that government will distribute masks. And government has started distributing masks. Now, we have issued guidelines on how to use masks. And we continue to encourage individuals to be responsible and wear masks while in public. Please wear masks while in public. Do not wait for the law enforcement officers to remind you that you need a mask. Your health is your responsibility. I thank you.
Thank you so much, Dr. Jenutha Cheng, for the time that you've given to us. And of course, I want to thank all the people that you've come with. It is just prudent that we do not, I personally can't or do not control social media. The minister doesn't, and I think the Science Professor Kalebu doesn't. We just need to see how to use social media responsibly. I think we can use social media to educate the public, to tell them good things, to preach to them what they need to do, as opposed to fabricating things that I think divert us, cause anger and rage, which is not necessary at this time. I want to thank all the other media houses that have carried this feed from when we began to where we are today, and of course thanking the management of UBC TV and all the production team, engineering and production. Thank you so much. My name is Jagenda Semakola Zekosoka, wishing you a very good night. Bye-bye, and God bless you.
you.